I can start.
Yeah.
So, good evening, everybody. I hope I am audible to those who are attending online. No? No one is hearing us, I think.
Yes, it's audible, sir.
It's audible, no? So, today's topic, as you can see, it is more of a initiative taken and not just a lecture. It's a initiation of quality assurance and improvement in fetal care services in Aster Medical Imaging. So it's not a lecture, it's more of a program designed where we'll be discussing how we can establish the standards, guidelines, and protocols and make it a part of our services. So we'll also have a continued training in the sense for all those who are interested in fetal medicine, whether they have any specialized training or no training, all of those who are interested in fetal medicine, we can have more and more CMEs like this one. This is the first one. We'll continue to have such meetings again and again so that we keep refreshing and updating our knowledge with the help of each other. And then we'll also have a audit program so that we can have some constructive feedback if we are missing something somewhere. And all these standards, guidelines, and protocols, what are there? These are international guidelines which we have to locally customize and fit it according to our setting. And from time to time, we have to update these guidelines. So who will set these guidelines? So it is not me or not anyone from management, it is you all the radiologists of AMI who are doing an excellent work. You're all guys, all of you are very fantastic. So all your work we want to consolidate and set it in a standard way so that whoever joins new into Aster, they too can follow these standards. So this is not just a presentation. This is an opportunity for me to invite you all to join this initiative of being the member of the quality team for fetal medicine. So two members who have already joined and who have guided me and supported me for this presentation. I would like to thank them first, Dr. Chandana and Dr. Kusuma. So why are we doing all this? So what are our expectations? So the main purpose of having this is to establish and ensure a minimum basic level of quality, which should be offered in fetal care services across all the units of our organization. So irrespective of whether the patient is going to Sharjah or Dubai, whether to Dubai or to Dera or to Abu Dhabi, anywhere the patient goes, there should be some minimum basic level of quality which the patient should receive. So that is our purpose of having this quality assurance program. And then depending upon our interest, we can keep on building beyond these basic guidelines. Also the ethics we have to consider here, that is if you find some of your colleagues who are doing very suboptimal scan, no matter how suboptimal it is, do not comment on their scan and do not agitate the patients that that guy has done such a bad scan. So never do these things. Remember that they say this karma is a bitch. That is, you screw someone today, next day you will get screwed. So always try to support your colleagues and take the patients in confidence. And so that is the thing, be good to all. And next thing is being practical. That is, we are not expecting that you should never miss an anomaly, because anomalies, we all know it's an worldwide acknowledged fact that anomalies can be missed in expert hands. No matter how expert you are, you can still miss the anomalies. So there may be some technical limitations. There may be some progressive anomalies which are not seen during your 18 to 22 week scan. Later they may appear. Effusions and all, they can appear anytime. So this is the reference of guidelines which I have gone through. The SFM, International Society of Ultrasound in Obstetrics and Gynecology, Fetal Medicine Foundation, NHS Trust Guidelines, NICE Guidelines, AIUM, ASUM, SMFM, that is Society of Maternal Fetal Medicine, ARCOG, RANSCOG, ACOG, and FIGO, and also some other guidelines. When you keep searching for the guidelines, you keep finding many things. But these are basically the ones which I have mainly used. The one from India, the Society of Fetal Medicine, and the three from UK, that is the International Society of Ultrasound in Obstetrics and Gynecology, the Fetal Medicine Foundation, and the NHS Trust Guidelines. This is because these guidelines are more relevant to fetal care, while the others are more of maternal care. And these guidelines were easier for me to put in because I have been trained in these places. So why do we need quality assurance for fetal care? That's because we want to optimize the antenatal care and give the best possible outcome for the mother and the fetus. And remember, if we do not follow the standards and do a substandard practice, then it is not something to be taken easy. It can lead to maternal deaths, it can lead to fetal deaths. So it's a very criminal thing if we are not following the standards. So these are some of the guidelines which I have come across. The guidelines for first trimester screening, and then the guidelines for first trimester complications such as miscarriages, ectopics, molar pregnancies, written products of conception, septic RPOC, AVM, EVM, all these things. There is a separate guideline for all these complications. Then the aneuploidy screening guidelines, preeclampsia screening and follow-up guidelines, second trimester screening guidelines, CNS screening guidelines, fetal heart screening guidelines, fetal neurosonography guidelines, fetal echocardiography guidelines, specific fetal anomaly guidelines. That is, for example, cardiac anomalies, there are specific guidelines for four-chamber view anomalies, for the great vessel anomalies. For different anomalies, there is a different pathway, how you will manage those anomalies, how you will counsel your patients, how will be the prognosis, all these things. For different anomalies, there is a different guidelines, different approach. So all these guidelines, and then the cervical assessment for preterm birth prediction and prevention, that also there are a separate set of guidelines. For placental assessment, there are separate guidelines. There are guidelines for fetal biometry and growth assessment, fetal well-being and biophysical profile, fetal Doppler guidelines, SGA and FGR guidelines are separate. Fetal infection guidelines are there. Multifetal pregnancy and complications related to multifetal pregnancy, such as TTTS, TAPS, TRAPS, all these things, there are separate guidelines. Discordant twins, discordant anomalies in twins, all these are separate set of guidelines. So medical disorders in pregnancy, fetal anemia, maternal diabetes, all these things have a separate set of guidelines. Assisted reproductive technology pregnancy, there is separate guidelines. Prenatal and pre-implantation genetic guidelines. Prenatal is something we'll be discussing today, the aneuploidy screening. Pre-implantation genetics, it refers to the PGTA, PGTM, and PGTSR, that is for aneuploidy monogenic disorders and structural reformations. There is separate guideline for those things. Then fetal medicine in COVID-19 pandemic. This actually, there was a symposium last year, AMI symposium, in which I have already presented these guidelines, fetal medicine and pandemic. So there are also safety related guidelines, safety of ultrasound and Doppler in pregnancy. There are counseling guidelines. This is one of the most important thing, patient counseling. So there are separate set of guidelines and how to counsel and how we go about. Then intrapartum ultrasound, there are separate guidelines. Fetal MRI is no longer just doing a MRI of maternal pelvis and saying this is the baby. It has become very dedicated and specific for fetal brain. You have separate protocol for fetal heart. You have separate protocol. So we'll go through those guidelines later sometime. For fetal interventions, what are the guidelines? And fetal therapy is a new baby, like spina bifida surgery, or maybe it is some shunts like vesicoamniotic shunt, or it may be a cardiac intervention, in utero cardiac intervention, such as balloon angioplasty for aortic stenosis. All these things we'll see at a later stage. Fetal medicine training and privileging, that also has a set of guidelines. Research in fetal medicine, of course, as we can expect, there is a guideline for research also in fetal medicine. So for training in fetal medicine, we'll follow the ISWAG style, that is the 3 levels of training: basic training, advanced, and expert. What are these 3 levels? Basic training is for screening scans like anti-scan, anomaly scan. These are the basic level screening. So this is what we'll be discussing today actually, starting from the basics. And then there is the advanced subspecialty level training, in which the high risk and complicated cases, how we will analyze these cases, how we will manage these cases, which need some advanced skills like fetal echo, fetal neurosonography, fetal Doppler, and it needs some clinical insight also for understanding the management and prognosis of the case. And with that, we can have some multidisciplinary discussions with the other caregivers for the baby. It can be the obstetricians prenatally or postnatally. It can be the neonatologist or the pediatric cardiologist, pediatric neurologist, pediatric surgeon, depending on what problem the baby has. Then the expert level is the research, where we find new things, we discover new things, and share it with our doctor fraternity for giving better care for the patient. So two such research which I have done, one is FTS and another is Y dot dot. This I will be discussing later in the presentation. So before going to the guidelines of the scans as such, first we'll go through some preliminary guidelines like who should perform fetal ultrasound and what equipment should be used. Is ultrasound safe in pregnancy? What if the examination cannot be performed in accordance with guidelines? And of course, before anything, basics first, patient history and all related reports should be checked before starting the scan, and take consent wherever needed, such as TVS or fetal interventions. So who should perform the scans as per the ISO guidelines, all international guidelines? Only individuals with specialized training in fetal scans should perform the fetal ultrasound. Now, there is always a limitation of such experts who are specialized in fetal medicine. So it's nothing to worry. We will have an internal training program, and we will have a tie-up with external experts to provide training to our doctors. So we'll make sure we are all getting proper training in fetal medicine. So what equipment should be used? If it is just for screening purpose, anti-anomaly, then even a mid-range machine is good enough. If we are giving subspecialty services for second opinions, for managing complex cases, then we need a high-end, high-resolution machine with 3D, 4D in it. So now, talking about safety of ultrasound in pregnancy. There are many different comments from different people that it can cause ADHD, attention deficit hyperactive disorder in the baby. For the mother, it can cause mechanical stress leading to heat production, gas bubbles, and cavitations. And therefore, they have put K as low as reasonably achievable. That is, scan time should be as short as possible. But don't worry about all these things because none of these have been proven. So till date, there is not even a single side effect of ultrasound which has been proven. So ultrasound remains a very safe modality for scanning in pregnancy. So what if examination cannot be performed in accordance with these guidelines? So we are going to discuss today what are the international guidelines for scanning the anti-scan and the anomaly scan. So there are many other things which we'll be discussing later stage. So today we are starting with the anti and anomaly. This I'm telling to some people here who have joined just now, so that they'll get an idea what we are discussing. So if the examination couldn't be performed in accordance with guidelines, then we have to mention what was the reason and what we couldn't see. For example, in some reports, we always find that fetal heart could not be seen due to poor acoustic window. So that is not a correct way of describing things. You tell which part of fetal heart you couldn't see and why you couldn't see, maybe due to fetal position or something. So be more specific and then repeat the scan. Maybe if you repeat the scan, the baby will be in a more favorable position. Or you refer it to some of your colleagues if you're feeling like you want a second opinion from other colleague. And this should be done as soon as possible to avoid patient anxiety and associated delay in achieving the desired goal. That is, if there is any abnormality, we should not be late in detecting it. So starting with the anti-scan, we'll not just talk about anti, we'll make it a complete first trimester quality assurance. So along with aneuploidy screening and the preeclampsia screening, we'll discuss it all. So how to schedule the first trimester scan, when the first trimester scan should be done, or how do we schedule the scans during pregnancy? So this is the pyramid of antenatal care. So according to this model, the first scan should be done at 16 weeks and then 24 weeks and 28 weeks and then 30 weeks, 32 weeks, 34 weeks, 36 weeks. And at the end of pregnancy from 37 weeks onwards, every week you keep on doing a scan. So what do we understand from this type of model? This kind of schedule for antenatal scans implies two things. One, most complications occur in third trimester. Another thing what it can mean is that the adverse outcomes of pregnancy cannot be predicted in early trimesters. So that is why you can see all the scans are piled up towards the end of the pregnancy and the first scan is only at 16th week. And this model is 100 years old. 100 years old, this model was described and this is the model which was followed for a long time. But now we know that pregnancy complications begin in earlier trimesters itself. Although they may manifest and complicate the thing at the end, but they begin in the earlier trimesters. And that is why early trimester scan, the first trimester scan is very important for risk stratification. So there is a progressively improving trend to identify maximum problems earlier in pregnancy. And by doing this early pregnancy scan, we can stratify the patient into high risk and low risk. If the patient is found to have some high risk, for example, high risk for preeclampsia, then we can shift the antenatal care from routine care to disease specific approach. And it has been proven that prevention and treatment is better if started earlier than later in pregnancy. And if the patient falls in the low risk category, then reduce the number of visits. We don't want too many visits towards the end of pregnancy, as we already know in the early pregnancy itself that the patient has low risk. So no need for doing repeated scans for such patients. So with all this knowledge, now it is the time to invert the 100 years old pyramid of care, and this is what we follow today, the inverted pyramid of antenatal care. The first scan is done between 11 to 13 weeks, 6 days, or roughly 14th week, in which we check for the gestational age, the number of the fetuses, and we screen for aneuploidy. We check the fetal anatomy. Many people still keep saying that in first trimester we cannot see any anomaly. It is not like that. We have to do a proper anatomy scan in first trimester itself. And then the anomaly scan at 18 to 22 weeks, where we also screen for the risk of preterm birth by cervical assessment. And then the growth scan at 34 to 36 weeks to look for late adverse outcomes. At 11 to 13 weeks, 6 days, what are the things we look for? One is the gestational age, and the other is the aneuploidy screening. The third thing we do is the preeclampsia screening, fetal anatomy scan. We look for fetal growth restriction and multifetal gestation, that is the number of fetuses. And we look for any first trimester complications. And if there are complications in first trimester, we can even ask for an earlier scan. And then if you're worried about the insurance, if we explain to the insurance that the patient has a risk, the patient has complications, then they will give approval for more than one scan in each trimester. Normally only one scan is approved in each trimester, but if there are complications, they are giving approval for the anti-scan as well as the dating scan together in first trimester itself. And then of course we look for the maternal pelvic pathology. And what are we going to do after checking for all these things? That is, we should not only know what to look for and how to look for, more importantly, we should know why we are looking for these things. For example, if there is aneuploidy, then you should know how to screen for aneuploidy and what we can offer to the patient like NIPT or invasive testing. If there is preeclampsia, then we can provide them prophylactic aspirin to prevent and delay the onset of eclampsia until term. And we can do the fetal anatomy scan to look for any anomaly. And early detection of anomaly means the patient has a lot of time to plan properly whether they want to continue with the pregnancy, and if they want to continue with the pregnancy, will they need further testing like genetic test. And if they continue, then they can prepare for the baby well if it is detected early in pregnancy itself. And then fetal growth restriction, how do we manage? There are separate guidelines. Multifetal gestation, there are separate guidelines to manage multifetal gestations. And for first trimester complications, also there are separate guidelines. So we'll be discussing these things separately at a later occasion. So today what we will be discussing is gestational age assessment, aneuploidy risk assessment, preeclampsia risk assessment, fetal anatomy scan in first trimester. So gestational age assessment, there are three things we look for in gestational age assessment. One is CRL between 11 to 13 weeks, 6 days. And if the baby is 12 weeks or older, then BPD and HC are more accurate, and they will be utilized for risk calculation in the double marker, that is combined risk assessment. So if the baby is 12 weeks or older, then just mention the BPD and HC also. AC and FL, there is no indication why they should be measured in first trimester. So CRL, I think the fonts are very small, but I'll just try to explain this. So it can be carried out transabdominally or transvaginally. First criteria for taking a proper CRL is that the plane of the baby should be a mid-sagittal plane. That is, the whole fetus should be seen in mid-sagittal plane. And the fetus should be oriented horizontally to the screen, not vertical, not head downwards, horizontally. Image should be magnified sufficiently to fill most of the width of the ultrasound screen. This thing is often missing in our images. We forget to zoom the image and take the measurement. This is also one of the quality criteria. Then the fetus should be in neutral position. Neither the neck should be too much flexed nor too much extended. Now, just to give you an idea how to decide whether the fetal neck is in neutral position or hyperflexed or hyperextended, you can see here the rectangular shape of the palate. So just the posterior margin of the palate, look at the width. If this width of amniotic fluid is present between the fetal chin and the chest, then that can be taken as a criteria for neutral position of fetus. Then the end points, that is the crown should be clearly seen, the rump should be clearly seen. Sometimes we see images, the crown is seen, but the rump is somewhere not seen at all. So we have to make sure that both crown and rump are clearly seen. And care must be taken to avoid adjacent structures like yolk sac. And in order to ensure that the fetus is not flexed, that is the amniotic fluid should be present. That point is the same which I explained already. So these are the criteria for measuring the CRL. Okay, now coming to assessment of fetal anatomy. What are the things we should look for in a first trimester for fetal anatomy? In the head, we look for, these are the ISO guidelines for first trimester fetal scan, fetal anatomy, what we should look for. In the head, we look whether the head is present or not. Obviously, what they are talking about is anencephaly. So we look for head, whether it is present or not, to rule out anencephaly. The cranial bones, that is acrania or cranial bones are there. And if they are there, whether they are intact or there is a normal shape, all those things. The midline falx, whether present or not present. Of course, here the thing what we have in our mind is a lobar holoprosencephaly where the midline falx is absent. And then the choroid plexus filling the ventricles. Now, in the first trimester, the baby's ventricles look different from the way they look in the second trimester onwards. So the ventricles will be broader and broadly all the choroid plexus will be filling the ventricles. We'll see the image next. Then the neck we have to scan whether the appearance looks normal. And of course, the main thing in the neck for first trimester is the nuchal translucency, which we'll check later while going through the aneuploidy screening. And the fetal face, we look for eyes and we look for the lens in the eyes, the nasal bone, the normal profile. We look for mandible, micrognathia, retrognathia, all those things, whether the lips are intact or there are clefts, all those things. Then the spine, the vertebrae should be seen in longitudinal and axial, minimum two planes, longitudinal and axial. If coronal is seen, well and good. The skin over the spine should be seen for intactness or if there is any defect in the skin. So in the chest, we look for the lung fields, effusions, masses, heart, cardiac activity should be regular, four symmetrical chambers. Now, this is the basic requirement for first trimester, four chamber view. But in the first trimester itself, great vessels also can be seen, although it is not mandatory. Just I will be sharing with you how we can see the great vessels in the first trimester. So in the abdomen, we have to look for stomach, whether it is present and what side it is present, decide the laterality and the situs, and look for the bladder and the kidneys, the abdominal wall, the cord insertion, whether any defects, the extremities, all four limbs are present or not, all three segments in each limb, proximal, mid, and distal. For example, in the upper limb, the humerus, in the forearm, the two bones, radius and ulna, and then the open hand. So hands and feet should have normal orientation. That is, leg and foot should be at right angle. Similarly, the hand should be at a normal position with the forearm. There should be no club foot or club hand. Then placenta for the size, texture. Of course, in first trimester, we don't give it as placenta previa and all because it is already low lying in first trimester. So the size and the texture of placenta, the uh, cord for three vessels. Now these are some of the images showing the BPD section and the lateral ventricles. The thalami are marked by T, and you can see the choroid plexus completely fill the lateral ventricles. And then in the fetal phase, the profile view showing the nasal bone, the mandible you can see here. This is the frontal bone. Just imagine a vertical line from here. You can see it will go through the mandible. If the mandible is somewhere behind that vertical line, that is micrognathia or retrognathia. Similarly, in coronal, you can see the nose, and here we can see the premaxillary triangle actually, and then the mandible gap should be seen. That is also for ruling out the retrognathia, micrognathia. These are the fetal eyes with lens inside. So in the neck, we look for NT that we'll discuss in aneuploidy screening. In the spine, this is the spine, the ossification centers for vertebral bodies, posterior elements, the intact skin. Then the thorax and heart. This is the heart in the center and the lungs on the sides and the spine posteriorly. And the abdomen, look for the stomach and in the coronal and come down again towards the umbilical cord insertion. Look for the upper limbs and the lower limbs of the baby. Now, these are the major anomalies which have 100% detection rate. So always look for them specifically. You can have this list with you. These anomalies should never be missed in first trimester. There are many anomalies which can be detected, but these are the ones which are having 100% detection rate. So they should always be detected. One is early hydrops, another is anencephaly, a lower holoprosencephaly, body stalk anomaly, ectopia cordis, where the heart is outside the chest, large omphalocele, large gastroschisis, megacystis, molar placenta. So this list, always have it with you. Be well versed with their appearances and always look for them in the first trimester scan. Now, these are all the images we went through. I'll give you a simple tip how to get all your views without wasting much time in the anti-scan. Just switch on the cine clips in your machine and increase the time of the cine to maximum and keep scanning the baby. Try to take a mid-sag position, not exactly, just try to make it, and the baby itself will move and give you the proper position. For example, the first video you can see there, the baby has already given the mid-sag position in which you can check the nasal bone, the nuchal translucency, the intracranial lucency. So all these things, you need not waste time. Just put the probe and wait for the baby to come in mid-sag and screen little bit side to side. So that entire thing you will get it in the clips. Down also we have another clip where we are seeing in axial and we are able to see the body of the baby and coronal. The limbs are also seen. And this is another clip, again checking the entire body. Just keep scanning across the baby, first in sagittal plane, then in coronal plane, and then take one sweep in axial plane. Here we are seeing the legs and the hands. And in this video, the hands, fingers. I think this is a long video. So basically what tip I am giving you is just try to take sneak clips. You'll get the entire picture of the baby. And if you get the mid-sag plane, then your scan is done for your NT and NB there itself. Like this, you can go through your cines and make the images whichever you want. Like for spine, we got this image, the coronal and the sagittal, and the baby's hand, the baby's leg. We are seeing the relationship of leg and foot, no club foot. We are seeing the fingers 1, 2, 3, 4. The thumb is here, if you can see that. The cord insertion and the kidneys and the bladder, the premaxillary triangle. So you can make it more like this, just by a little bit flipping the image. So in the premaxillary triangle, look for intactness of the palate, whether any clefts are there in this. And then we are checking for the baby's heart. Just in the axial plane, put over the heart, we'll get the 4-chamber view. If you go up, this is the 3-vessel view. And now when you are rotating the probe, you are getting the transverse aortic arch. The ductal arch is there. So just you can put it in dual, so you'll get the color view also. Now, anyhow, you'll be scanning the heart of the baby just while you're looking at these 4 chambers and the great vessels of the baby. You know very well where is the right atrium, the right ventricle. This is the tricuspid valve. So right over there, you have zoomed in the image already. Just put your power Doppler cursor and you will get very good tricuspid flow. So what are the parameters for tricuspid flow? We'll see it in the aneuploidy screening. So how should this scan be documented? So properly in a standard format, in a structured way, we have to report it. This can be done with the help of software, that is a fetal medicine reporting software. The advantage of these softwares is that will not only give a structured report, but we also get the percentiles for all our measurements. And also they have the facility of calculating the risk for aneuploidy and preeclampsia. And they give the charts also like this. So presentability is also good in this. Now coming to audit. How are we going to audit the cases? So we have a general review form for radiology, but that doesn't serve a good purpose for fetal medicine. So for fetal medicine, we'll try to follow the audit guidelines from NHS, and also in Fetal Medicine Foundation, they follow the similar guideline. So for CRL and NT, there are 1, 2, 3, 4, 5, 6, 7 common parameters which they look for. And then for CRL, there are some separate parameters. For NT only, there are some separate parameters. So for CRL, 1, 2, 3, 4, 5 more parameters. For NT also 5 more. And 7, 1, 2, 3, 4, 5, 6, 7. 7 plus 5, that is 10, 11, 12, 12 parameters. 12 parameters for CRL, 12 parameters for NT. That is how we audit these scans. And then we also see how is the reporting for the case, and how was the image optimization done, whether the image was zoomed properly, whether the calipers were placed properly, whether the plane of the image was proper. So all these things we take into consideration, and we score how much was correct, how much was wrong, maybe around 90 to 95%, we give it a pass. So now what are the actions depending upon the how the scan has been performed? If there is no further action required, that is the scan was done well, then you can give a review like this: really nice images, well done. That means their images are near to 100% acceptable. So if that is not the case, then a further 3 paired images should be reviewed for that particular radiologist or the individual who has done the scan. And if that is also not satisfactory, then observe the technique, how they are scanning. Go with them and see how they are doing the scan. And then discuss with them one-on-one image review. Sit with them and discuss what is their view, and then understanding what is their level of knowledge, you can guide them better. And if all this is not working out, then put them through a e-learning resource. Let them learn first and then do the scans. So this is the audit form which they use in NHS and Fetal Medicine Foundation. So we too can apply something like this. This is our plan to have something like this for a quality assurance program in AMI. Now for anomaly scan also we have a audit program. And if someone has observed, this is my own anomaly audit for Fetal Medicine Foundation in London. So this is how they audited everything. All images were accepted and they gave me this compliment. Really nice images. Well done. So now for that was about the first trimester anatomy screening and the CRL. NT we will discuss in aneuploidy screening. So that's a separate PPT. Just I'll open that. And I think Rebecca can help in this. Yeah, now coming to aneuploidy screening. So what we have to understand that when the patient is coming to us, we are just checking the NT and sending the patient, go, your obstetrician will tell you what to do. So this is not what we are going to do. Otherwise, your obstetricians really will start treating you like sonographers. So you have to understand that you are a doctor, you are a fetal medicine specialist. Even if you are not, you are going to become a fetal medicine specialist. I hope you all have interest in fetal medicine. That's why you are all here. So we have to understand that the mother is the patient of the obstetrician, but the fetus is our patient. So we have to take care of our patient. We have to follow up with the patient, that is through his mother and through the obstetrician. We have to take care of our patient through the obstetrician and through the parents of the patient, that is the fetus. So aneuploidy, it's altered number of chromosomes. Trisomy 21, 18, 13 are the commonest ones. Monosomy X, that is Turner syndrome. Triploidy, double XY and triple X, these are all the aneuploidies. We are not looking at structural malformations and all. These are just the number of chromosomes which are altered. So these can lead to miscarriages or at a later stage in pregnancy, fetal demise. The baby may be born dead, stillborn, and may die earlier within 28 days of life. That is neonatal death. So that is the effect what aneuploidy can have. Even if the baby survives, the baby will have mental retardation and other several forms of disabilities and can lead to an, infertility in the mother, secondary infertility. So how do we screen for aneuploidy? So screening is done not by one single factor, but by taking a combination of multiple factors into account. So these factors can be maternal factors such as maternal age, weight, ethnicity, whether IVF or naturally conceived, number of fetuses, diabetes, smoking, previous affected child. These are all the maternal factors. Ultrasound markers are NT-NB-DVTR. We will go through all this. Not used anymore are the FMF angle and the hepatic arterial flow. So they do not add much to the detection rate and are not needed anymore. Biochemistry, we have double marker, triple marker, quadruple marker. Double marker is free beta HCG and PAPE, which we perform in first trimester. And in the second trimester, there are two tests, triple marker and quadruple marker. Triple marker, we are no longer doing because as per ISPD guidelines, for a test to be validated, it should have minimum 75% detection rate. But triple marker has only around 69% detection rate, so that is no more valid. Even if you find your obstetricians asking for a triple marker, this is something what I have actually found in my place. So just tell them, madam, this is not the way we are doing things anymore. Ask for a quadruple marker. So that is better in the second trimester. And then in the second trimester, also we'll be doing the ultrasound anomaly scan, look for the soft markers, all the various soft markers, they form together the what we call as the genetic sonogram. So that can also be taken into account to decide how much risk the mother has for aneuploidy. Uh, Then the role of cfDNA, that is NIPT or NIPS or harmony test, and what we should do when the cfDNA test fails. This all will look into it. And what is combined test, what is integrated test. Combined test is the first trimester test. We are taking into account the maternal factors, the ultrasound markers, the biochemistry double marker, free beta hCG and PAPA. This all together is known as combined test. Now, in the second trimester, if the baby is coming, and we are doing a quadruple test for that baby, and we are finding some soft markers in that baby, then all these things also we have to integrate with the risk which was already done in the combined test. So that is known as integrated test. So basically what we are doing, the baby initially there is a risk. This is known as a priori risk. That is, every mother has a risk that the baby of that mother may be born with a chromosomal or genetic abnormality. So that is known as a priori risk. That is previous risk. That risk is always there. So with that, we are going on adding more and more markers to make a guess whether the baby has increased risk of aneuploidy or less risk. That is, there is very less risk of having it. Of course, these are all screening tests where we are just trying to estimate and calculate the risk. The diagnostic test is the CVS or the amniocentesis. So what is this actually we are doing to understand this? You can think that these are like symptoms of a disease. For example, if I have headache, does it mean that I have brain tumor? Very less chance headache, but there is still a risk. But if with that headache, I have blurring of vision, then there is more risk that I may be having brain tumor. And then we take another symptom, projectile vomiting, then even more the risk of having a brain tumor increases. This is exactly what we are doing here. We are taking into account various parameters to make a guess how much risk the baby has for aneuploidy. So we'll stratify the risk as low, intermediate, and high risk. And depending on which category the patient falls, we offer them the diagnostic test, CVS and amnio. Now, a positive screening do not scare the patient. It's after all only a screening test that there is some chance, but there is also chance that the baby may be normal. So just to ensure that the baby is normal, we may have to do either a NIPT or go ahead with invasive. Like that, you have to convince. Now, since some of you have already started sleeping, I will discuss a real life case with you. So it's okay. It's like a little bit boring, I can understand. But now we'll discuss a real life scenario. You think that I'll explain how this patient came to me. You think, okay, to you, if the patient comes, what you would have done like that. So this patient came for a pelvic scan. We did TVS. Everything was normal. So I told the patient, okay, scan looks normal. But the patient did not look happy. She reacted as if I'm telling her she has cancer, that type. Then I tried to convince her, oh, congratulations, everything is normal, scan is normal, like that. But still she is not happy, like a question mark on her face. Then she told, okay, doctor, I have one question. So she said, okay, 8 years back, my scan was normal. Now also my scan is normal. Then why I am not conceiving? So this was her question. I said, okay, see, it need not be very structural abnormality always. There may be like a genetic or endocrinal or environmental. I kept on discussing with her. Repeatedly, she is asking me in between again and again, same thing. 8 years before my scan was normal. Now my scan is normal. Then why I am not conceiving? So then my assistant who is there, she understood that this is some psychological problem. She tried to convince the patient and take her out. Then she went out and immediately she came back, opened the door and asked again, Doctor, are you sure everything is normal? 8 years back also my scan was normal. Now also my scan is normal. Why I am not conceiving? Again, she started the same thing. Then again, my assistant, she convinced her and took her out. Then my assistant lost patient and she said, sir, how can you have so much patience with these people like that? Then I said, something flashed in my mind that time actually. I told, call her back. She told, seriously? I said, yes, go call her back before she leaves the clinic. And then that patient came back. Then I told, I have one question for you. 8 years back, your scan was normal. Now your scan is normal. Then why you are not conceiving? So what flashed in my mind is this patient has some history and she is trying to know okay, whether this doctor will be able to guess it out. So, and that was exactly the thing. When I asked her this, why your scan was normal 8 years ago, now it is normal, then why you're not conceiving? She gave the answer. She told that 7 years back she had conceived. And then the double marker, the combined test, this thing was done. It showed a very high risk. And the obstetrician scared the hell out of the patient that there is very high risk. The patient did not bother about anything. Directly, she went back to Nepal. She's a Nepali. She terminated the pregnancy. Later, she was having difficulties in conceiving. She went into secondary infertility. Then she met many doctors. She showed all her old reports. And then she showed me the double marker report, which was very old already. So double marker is showing the placental factor normal, the fetal factor normal, maternal age is not too much. Then from where this high risk is coming? The high risk was coming from the NT of the baby. The NT was not something like 4, 5 like that. It was just 2.8 or something in that range, less than 3. And then when I asked for the NT image, she said, no image, I have the report. Images are old and not there, but reports she had, she showed in her mobile. The report is saying NT 2.8, normal less than 3. So this point will come to it. So many mistakes are done here. First, the obstetrician scaring the hell out of the patient and not offering the diagnostic test, not even asking for NIPT. Just when you scare the patient will not listen to anything. They will go and terminate. This is how it is. So we have to be very careful in counseling the patient. And then you see this habit of taking 3 NTA as normal is very dangerous because for example for 11 weeks gestation or 11 and a half weeks gestation, even a 2.5 2.6 will be very high. So we have to follow the percentiles and nowadays easily the calculators are available online. Just put your CRL and NT, it will show which percentile the NT is coming in. If it is coming very high, you can repeat always and check and confirm first that your technique is proper, the NT is proper. Otherwise, like this, the complications will happen. Just one wrong NT measurement and the patient went ahead and killed a normal baby and never had a baby again. And then she went into self-guilt that I was in a haste. I took a very fast decision and terminated the baby. God's gift, now God is punishing me. All those things. She went into that mental disturbance. So, like this, if you are not serious about these things, if you are not doing a dedicated work on this, they can complicate the lives of people in this way. So, I think with this story, some of you might have got up now. So this is just the detection rate of various tests. Maternal age alone has very low risk, and the highest risk is with cfDNA. But cfDNA directly we are not offering to everyone. We are going with the combined risk first. If it shows intermediate risk, then we are going to cfDNA. Why like this? That we'll discuss. So first of all, the NT measurement, how it should be taken. As per the guidelines, NT measurement should be done by trained, certified, or locally privileged operators. And it should be taken in between when the CRL is 45 to 84 mm. NT can be measured by a transabdominal or transvaginal route. The fetus should be in neutral position. Neutral position, I already explained you to look for the pocket of amniotic fluid between chin and chest. Then the sagittal section should be obtained and image should be magnified in order to include only the fetal head and upper thorax. So next point, amniotic membrane should be identified and separate from the fetus. One of the reasons why we give very high NT when you're seeing in the reports like 3, 3.5, what they do is instead of measuring the NT, they measure the distance between the fetal neck and the amniotic membrane. This is a very common mistake. So first identify the amniotic membrane, make sure that it is separate. Then median view of fetal face. So we are talking about the mid-sagittal plane. So how do we identify that mid-sagittal plane? For that, the echogenic tip of nose, this is the echogenic tip of nose that should be seen. And then the rectangular shape of palate, this is the palate, this should be seen. And the translucency of diencephalon, they mean this thing here in the center and the nuchal membrane posteriorly. This is how they have defined the mid-sagittal plane. This is the FMF guideline. But one thing which is not mentioned in FMF guideline, very easily we can pick up that, very easily we can get the mid-sag without saying other things like this. First, if we focus that, all these things will come in line. So that is again one of the research which I have done, still not published. After it is published only I can say, because we can always say, okay, I have found something new, but that should be approved by some international society. Then only we can say, okay, it is valid. Oh. Okay, now what if the mid-sag plane is not there? If the plane is not mid-sagittal, then you see the zygomatic process of maxilla here. Extra bone, that is instead of lucency, you'll see the bone over here. And then after making sure we have got a proper mid-sag plane, zooming it properly, and you have to lower down your gain. I don't know whether that is mentioned. Yeah, it is mentioned here to get rid of the fuzzy margins, and then place the calipers in such a way that the plus mark caliper, these calipers should be used, and the horizontal arm of the caliper should be along the margins of the nuchal translucency, on to on measurement. This is how we put this. We are taking care so much because even zero point 0.1 millimeter of difference in NT will make a lot of difference in the combined test risk assessment. It's not 1 mm, 0.1 mm will also make a lot of difference. So if more than one measurement meeting the criteria is obtained, then the one with maximum measurement should be taken into account. Now, single cutoff of 3 mm, I was telling you, is very dangerous. So for example, if we see for the CRL of 45 mm, 2.2 is the 95th percentile. So if you give here 2.3, then for a CRL of 45, even 2.3 will be high. So if we are taking 3 as the cutoff, then you can see 3 is the cutoff only at 85 mm CRL. And that means this is the last limit when the baby is fully grown, that time we are taking this. Otherwise, this nowhere it is meeting the 3 mm criteria for 95th percentile. So better check with the percentile chart where the CRL and what the NT should be. And nowadays, no need to even check these charts and all. Just use the online calculator. For example, FMF calculator, just put CRL and NT, it will show you what percentile your NT is. And then the other thing we should look for is the nasal bone in the same mid-sagittal plane, how we took for NT in that same plane, just slightly to the side, because in midline you have a gap between the nasal bone. So slightly you may have to tilt the probe and then you will get the nasal bone. So one patient, the NT scan was done, very beautifully midline plane was taken, and the nasal tip was seen and the bright nasal bone was seen. But when the patient came for anomaly scan, there is no nasal bone. So what was the mistake? They took these things as nasal bone. You have to understand that this is the skin. This is the tip of the nose. The third echogenic line here, below the skin and tip of the nose, that is the nasal bone. So this is what we should always keep in mind. There are three echogenic lines. The third one, the deepest one, is the nasal bone. Ductus venosus flow, again, zoom the image properly. The thorax and abdomen of the baby should occupy almost all of the screen, trace from the umbilical cord entry where you see the aliasing. That is the area of the ductus venosus. Put your power Doppler here and get the waveform. And the waveform you will get like this. This is the positive A wave in the waveform. Now, some of you are giving the M patterns in ductus venosus. So some of the articles I searched what is M pattern. So they have described it, but they have described it as marker for FGR. So later you can let me know if there is something else about the M pattern. But what is described in the standard guidelines is to look for the A wave. This filling in between these waves is the A wave. If this is reversed like this, then that is a abnormal ductus venosus flow. That is how we qualitatively assess the ductus venosus, whether the wave is positive or absent. That is normal. But if it is reversed, it is abnormal. One thing we have to keep in mind, which Dr. Kusuma may be remembering. So we always have to keep the sweep speed very long so that we do not get overcrowding of these waves. If we get overcrowding of the waves, these venous contaminations will look like a reversed A wave. But when you increase the sweep speed, that is, you spread out the waveforms like this, then you will see clearly okay, there is a wave in between there. So that is always you have to keep in mind. Now for the tricuspid flow, already I showed you in a clip before. When you're checking the fetal heart, just put over the tricuspid valve, the caliper, keep a wide gate. And then when you put on your Doppler, and even in this you have to remember the same technique what we did for DV. The sweep speed should be high, very high, like 200 to 300 milliseconds, so that we get very nicely spread out waveform. This is the normal with no regurgitation. This one has long regurgitations here. So 60 is the cutoff, more than 60 is tricuspid regurgitation. And that 60 centimeter per second should last for approximately half of the systole. That is just a click here and going like that. That is not a tricuspid regurgitation. It should last for more than half of the systole like this. Sometimes you can, due to contamination from the aortic valve and all, you will get some high flow jets. But again, there will be around 50 centimeter per second, that much. So that is why we take the 60 centimeter per second as the cutoff for aortic regurgitation. Now, after considering all these parameters, we finally have to categorize the patient into high risk or intermediate or low risk. This can be done by using the fetal medicine softwares, where just you enter your data and the software will automatically calculate and give you how much the risk is. So we'll be getting these softwares in AMI also, hopefully. Now, the risk cutoffs are taken differently by different people. In lab reports of double marker, if you see the standard thing is 1 in 250 they mention, but such cutoff we cannot take because once if we take that risk of 1 in 250, then many women will get who are in high risk. And we, for high risk, we are offering invasive testing, amniocentesis, which has a risk of abortion, although the risk of abortion is a little bit less than 1%. But if you tell that to the mother, okay, we want to do a test and only 1% risk of abortion is there, then she will not accept such things. It will be a disaster for her. So for us, it is okay, 1% risk, but for mother, it is a big thing. So we should always try to keep the risk lower, 1 in 100. Some people say it should be even lower, 1 in 50. Some people say make it even lower, 1 in 10. So it varies. It is not fixed, but anything 1 in 100 or more than this is a high risk. So we have got our risk by using the softwares, and we have categorized our patient as high, intermediate, and low risk. Now, what is the pathway we should follow? If the patient has low risk, then just continue with the second trimester scan. If intermediate risk, offer cfDNA, NIPT. And if cfDNA is negative, then just continue with the second trimester scan ultrasound. And what if the CFDNA is positive? If it is positive, we have to go for invasive testing. In any case, if combined risk is coming high, then directly do the invasive testing. Now, while you are looking for NT, NB, DV, all these things for the soft markers, choroid plexus cyst, echogenic intracardiac focus, which have low risk, or the higher risk like nuchal fold thickness or echogenic bowel, all these things you calculate the risk. And if you get somewhere around intermediate risk, you go to this protocol. And what if you get something like say like cardiac anomaly, like AV canal defect or a great vessel conotruncal anomaly, such things, then what test will offer? Double marker or directly NIPT? So none of those, because anomaly is anomaly. That means the baby is abnormal. As I told you, all the markers which we are taking, they are just like symptoms of a disease. We are trying to make out whether the baby is normal or not normal. But once in ultrasound you have seen an anomaly, that means the baby is definitely abnormal. So no need for making all these calculations and all. Directly we have to go for invasive testing, which is a diagnostic test. So intermediate risk on double marker, do cfDNA. What if cfDNA fails? Failed cfDNA, that report will not come as failed NIPT. They give it as no result or no call. They say that the fetal factor was less. Now again, if fetal factor is less, then this often happens when the patient is obese with high BMI. Now again, these are the same patients in whom amnio will be difficult. So ultimately, we will be left out with nothing, no risk assessment. So this is the problem of going directly for NIPT. So the better protocol is do a combined screening first, and then if that is showing intermediate risk, then go for NIPT. So that you will have something to fall back upon in case if NIPT fails. So you do the ultrasound after a failed cfDNA. If there is anomaly, go for invasive. If there is a soft marker, calculate the new risk. If the new risk is coming high, go for invasive. If it is still intermediate risk, repeat the cfDNA, then categorize as positive, invasive, negative, nothing to do, normal follow-up. And if for the second time also cfDNA fails, then this intermediate, you consider it as low itself and tell the parents there is low risk. So what if the ultrasound is normal after this thing here? If we are following the ultrasound and if it comes normal, then nothing, just routine care should be followed. So many things are there. What will suggest to the patient, which is the best thing? We are not going to suggest anything. We can just offer to the patient. We can tell them what is the benefit and the pros and cons of each test, and the patient is the one who will make the decision. So that was about aneuploidy screening. Now, another thing what we have to screen for in the first trimester is the preeclampsia screening. So as you saw, it is not just doing a scan and telling the patient to go to obstetrician. You have to know how to manage your patient, that is your fetus. And you have to work with the obstetrician and through the obstetrician to take care of the fetus. Only then you are doing a proper fetal medicine practice. So now the next presentation, it is about preeclampsia screening. Preeclampsia We are all aware of it. It is a major killer of mothers and babies. 8 mothers and babies die due to preeclampsia per hour. That is, I think I have been speaking now for almost 1 hour. That means till now 8 mothers and babies have died due to preeclampsia. So multimodality screening, same like what we followed for aneuploidy screening. For preeclampsia screening, we have to follow it in the same way. Maternal factors, biophysical factors, that is the ultrasound marker, uterine artery PI, the maternal mean arterial pressure, and then the biochemical markers, the placental growth factor or the PAPE. And nowadays they have introduced the S-fleet 1 to PLGF ratio, which is again thing which we have to think about, because PLGF itself, the patients say okay, it is very expensive and not covered by insurance. Um, Now there are two types of preeclampsia, preterm and term preeclampsia. Preterm preeclampsia has a strong association with defective placentation, that is the spiral arteries do not form properly in the placenta. So that is a placental problem, whereas in term preeclampsia that is not a problem. And maternal risk factors are less significant in identifying preterm preeclampsia, whereas they are more significant in identifying term preeclampsia. So term preeclampsia, more than 37 weeks, the only cure for preeclampsia is delivery. So this is not what we are actually worried about, because already the patient will be at term. If she develops preeclampsia at that time, we can deliver and the story is over. But preterm eclampsia, which develops before 37 weeks, or the early preterm eclampsia, which develops before 34 weeks, these are the things which we want to estimate and avoid in the form of giving prophylactic aspirin to prevent and delay the onset of preeclampsia. This is the pathophysiology, which I already told, that the spiral arteries are not well formed, leading to placental pore formation, hypoperfusion. So when the placenta is hypoperfused, it will release some pro-inflammatory things in the mother's circulation, which cause endothelial and platelet damage. That is how the all the morbidity and mortality of the preeclampsia comes. So these are the maternal risk factors. This list we can have in our room. Every mother keep asking these things. So again, we are going just beyond the scan and taking proper care of the patient. Uh, then the maternal factors alone, they can detect the term preeclampsia, but they are not good enough to detect preterm preeclampsia. Hence, we need more factors, biophysical and biochemical markers, to give a combined risk to the patient. The biophysical markers are in the form of mean arterial pressure and uterine artery pulsatility index. Mean arterial pressure, it's blood pressure, but it is not just the mean of right arm pressure and left arm pressure. That is not what is mean arterial pressure. Mean arterial pressure is diastolic pressure plus 1/3 of pulse pressure, and pulse pressure is systolic pressure minus diastolic pressure. So this calculation you have to make for each arm 2 times, right arm 2 times and left arm 2 times, and not one arm at a time. Both arms should be measured simultaneously, and the arms should be at the level of heart. That is using a double armed chair, just like how I am sitting now, like that, like this. If they sit, then simultaneously the blood pressure should be measured not by the routine sphygmomanometer, but a properly validated and calibrated um, automated device. And then the correct cuff size for the patient should also be selected, not small for large arm, not large for small arm. Proper size we have to decide. And train your nurse. What I'm telling this is again and again, don't just do the scan and tell the patient your obstetrician will tell you what to do. All these things you have to take up the responsibility. You have to take the history. You train your nurse on measuring the BP. Ask your head nurse to arrange for the automated device. It's not a very big thing to arrange. So set up your practice in such a way, and then only it is a proper fetal medicine service. Now that is how we measure the mean arterial pressure. Next thing what we measure is the uterine artery pulsatility index. So this can be done transabdominally or transvaginally, but in 11 to 13 weeks for estimating preeclampsia risk, it has to be done transabdominally because all the research and normograms what they have published is taken through a transabdominal approach. So for measuring uterine artery PI, again, we don't use the traditional way of iliac vessel crossing 1 centimeter downstream, not that technique. We use another technique that is uterine artery at the level of internal os. So how do we get and why should we do this uterine artery PI at the level of internal os? First of all, it is 15% more specific and also 15% more sensitive than the traditional way of PI at iliac vessel crossing. So how do we get this uterine artery at the level of internal? Take a mid-sag section of the cervix, then keep your probe there at the mid-sag section. Do not move the probe from there. Just tilt your probe. Tilt your probe to the right side to the periphery of the cervix at the level of internal os, and then you will start, your color box should be on, and you'll start seeing the uterine artery pulsating there. Put your power Doppler on, you'll get the waveform. Same thing, repeat on the left side, keep the probe in midline. Do not move the probe, just tilt it towards the left side, and with your color Doppler on, and when you start tilting it to the left side, the uterine artery will start blinking again on the left side. Put your power Doppler, take the measurement. So mean of both sides should be taken, that is left plus right by 2. Angle of inclination less than 30 degrees. The sample box for power Doppler should be, sample gate should be 2 mm, that is to cover the entire width of the vessel. And again, we have to note here the subjective thing of notching of uterine artery. This is something outdated again because it has very low specificity. That was about. Hmm? Mean PI is you will take PI for right uterine artery and you will take the PI for left uterine artery. Again, we do not take here, just like NT, we do not follow a single cutoff. We have to go see here. We have some normograms published for them. We have to check how much PI we are having, how much is the normogram, whether it is normal or high. And if it is high, then try to repeat again and make sure that your technique is correct. And then only send it forward for risk assessment. And the good thing is now we are not depending on labs to give us the calculated risk. So with the fetal medicine softwares, myself and Dr. Chandana and Dr. Kusuma had this just demo of the softwares. If we have these softwares with us, we can do it all ourselves. Just we have to enter uterine artery PI, how much is there. There will be options for maternal risk factors, those we can enter. Now, even if we don't have softwares, Fetal Medicine Foundation on its website, it gives the calculator for risk assessment for preeclampsia. All these options will come. Maternal risk factor, how much is the age, whether she is smoking, whether naturally conceived, what ethnicity, all these things you enter. Then you enter your mean arterial pressure. Then you enter your main uterine artery PI. Then the serum biomarker, placental growth factor. So this the lab will give you how much is the value. So enter all these things into the software, or either your commercial software which you will be buying, or the free software from FMF website, and you will get the risk of the patient for having preeclampsia. So these things I think we have already, this is exactly what I was discussing just now. Final risk calculation is by lab, but nowadays we don't have to depend on them. We have free FMF calculators or the commercial softwares. Now, a risk of 1 in 100 is good enough for preeclampsia. We don't want to make it 1 in 50 or 1 in 10, because at the most what we are going to do here is not something like aneuploidy. We were saying 1 in 100 may be too much, like 1 in 50 and all we have to take, or 1 in 10. That cutoff we can take, because there we are going to do amniocentesis, which can cause abortion in the, which is invasive thing, and there is risk of abortion. But here at the most, what we do is give aspirin. So 1 in 100 is a good risk cutoff for preeclampsia screening. Any woman who is having more than 1 in 100 risk, we start low dose aspirin of 150 milligram per day. So this prevents and delays the onset of preeclampsia up to 34 weeks if started by 12 weeks, as placentation is complete beyond 16 weeks. So after 16 weeks, if you are starting this, it will not have the same effect. It will have very less effect, negligible effect. So the ideal time is 12 weeks. So we have to assess the risk at the 12-week scan. So lower doses less than 150 if you give, then there will be aspirin resistance. This is the, as per the Aspray trial, they did one study, Aspray trial, and found okay, this is the good dose, this is when it should be started. And higher doses without indication. No, this is actually what is happening. I discussed with some obstetricians also. They are saying either we'll take only maternal factors into account or will not ask at all, we'll give aspirin to all. So aspirin has some side effects like GI bleed, intracranial bleed. So it's not like you are giving some toffee to someone. It is a medicine. So you have to be careful for that. Now, maternal risk factors, I told you the risk assessment will be very poor if we go only by maternal risk factors. We have to take all the factors into consideration. So the tablet should be given at bedtime, which is the better time than lunchtime, because the studies indicate that given at bedtime, it will have more benefits in terms of lowering preeclampsia, FGR, preterm birth, and IUFD. All the effects are better if given at bedtime. If taken as described above, that is, if the patient compliance is good, then with aspirin alone, preeclampsia can be reduced by approximately 90% for up to 32 weeks. So that was about first trimester quality assurance. So now we go to the second trimester guidelines. We'll try to make this faster because I think all of you are not able to survive. So this will be more interesting because this is more of ultrasound, the second trimester scan. So second trimester scan, the practice guidelines, we check for fetal number, viability, biometry, fetal anatomical survey, fluid cord, placenta cervix, and maternal pelvis. Now, all these things are the things which are routinely doing. We'll go directly to the point, that is the fetal anatomical survey. These are the ISWAC guidelines, what all things you should look for. In the head, you look for intact cranium, cavum septum pellucidum, midline falx, thalami, cerebral ventricle, cerebellum, cisterna magna. Then in the face, look for both orbits, median facial profile, mouth present or not, that is the lips, upper lip is intact, palate, lips, all those things. In the neck, look for any mass like cystic hygroma or a fetal goiter. In the chest and heart, look for cardiac activity, look at the lungs, then the shape of chest, any skeletal dysplasia. Then coming to the heart, cardiac activity, four-chamber view, the aortic pulmonary outflow tracts, any diaphragmatic hernia. So this is the basic cardiac scan, four-chamber view and the outflow tracts. Then they came up with the extended basic, which is also mandatory to be done. That is the great vessels, how we look for it, three vessel view, three vessel trachea view, the arch views, all that we'll see next. Then in the abdomen, you will look for the position of the stomach, that is will decide the laterality, and the bowel, kidneys, the cord insertion, skeletal, the spine and the limbs. Then at the end, look for the placenta cord and also look for the genitalia. In India, of course, it is banned, but in this country, I was just checking whether gender revelation is banned here or not. But rather, what I found is they are recommending to reveal it. So if in case any gender revelation problem is there in this country also, then let me know about it, because I tried to find about it. All I have found is they are recommending us to reveal it to the parents. In India, of course, there is a problem of female feticide, female infanticide. That's why PCP and DT Act is strict there for not revealing the gender. Now, how do we get all these things? These are the plans which we have to take. So if we keep in mind, okay, the patient is coming for anomaly and we make sure okay, these plans we have acquired, then there are 50 common anomalies which will definitely rule out in this. So every anomaly, as I said you in the beginning, cannot be ruled out in the scan. So there is a chance that you can miss any anomaly by any person who is doing the scan. But there are 50 anomalies which will definitely rule out by taking these 20 planes and 2 sweeps. First sweep, you will get the overall view of the baby. You look for the head and body, take the initial orientation. Then for the spine, you'll look for the sagittal view, coronal section of the spine and body. In the head, transventricular, transthalamic, transcerebellar plane. These are the set of images which you have to mandatorily acquire in every anomaly scan. In the thorax, look for lungs, four-chamber view, LVOT, RVOT, crossover of LVOT, RVOT. Then the three-vessel trachea view. In the abdomen, look for the stomach umbilical vein, look for the cord insertion, the kidneys, the pelvis. Here, what they mean is the renal pelvis. And then you come to the fetal pelvis as such and look for the bladder, both umbilical arteries on sides of the bladder. Look for the limbs, 3 segments of each limb, and that is in all 4 limbs, all 3 segments, proximal, middle, and distal should be present and normal. Of course, now one thing just I will discuss after this, the face, coronal, upper lip, nose, nostrils, both orbits and lasers, the median facial profile. Then the final sweep from head to toe of the baby, that is the head to the sacrum, neck to the sacrum. Head we can screen separately. The neck to sacrum, just at each vertebral level, take a transverse section, sweep your probe across each vertebra, and at each level, keep seeing the anatomy of the baby. So that is how we finished it, 20 planes and the 2 overviews. So these are all the anomalies which can we can rule out in each plane. So initial sweep and the first 2 planes for spine, those are the anomalies which we can rule out. Then you can see here in each plane for head, you can rule out this set of anomalies. In the thorax, you can rule out this set of anomalies. So like this systematically, if we go keep checking each thing according to a protocol, then we'll not miss the anomalies. It's a very rare chance of missing any anomaly in such situation. So we should make sure that we follow the protocol. And protocol does not mean that you have to check the head first, then the neck, then the thorax, not like that. Whatever is coming first, you can be opportunistic and check that first. But have a list of all these things. Either you yourself keep taking it or tell your assistant to take it. Or if you have a structured report format, you can just to dictate to your assistant, she will keep taking whatever you have checked. And many times, if you have trained assistant, she will herself ask you before completing the scan, have you looked for the LVOT? Have you looked for the RVOT? Did you see the 4-chamber plane? The assistant herself will remind you everything. So it's a very good habit of training your assistant with the protocol and make her check each and everything in every scan. Now, what is the criteria for referral? For suppose an anomaly scan is after all a screening scan. So when you will refer it to a fetal medicine specialist. So any appearance. So now what they say is these all planes which we have described here. These planes, each plane practice 100 images of each plane. 100 images if you're practicing, then after that, if you're not able to acquire that plane easily, then first thing that should come to your mind is not that the plane you are not able to get, that your technique is not correct. No, if you're not getting that plane, first thing you should think is there is some anomaly, that's why I'm not getting the plane properly. But for that, first you have to practice all the planes. You have to get used to them, and then once you are not getting them, first thing think it is abnormal. Refer it to fetal medicine, or you yourself get trained to be a fetal medicine specialist and handle the case. We'll discuss how we can handle them. Other things, biometry outside the normal range, and some soft markers. They have categorized as indication for referral also, such as renal pelvic dilatation more than 7 mm or ventriculomegaly more than 10 mm. So these are some of the images which were given with the guidelines. The first one is the BPD transthalamic view, and the second one is for the AC with the stomach umbilical vein at the level of portal sinus, then the femoral diaphyseal length, not the epiphysis. Sometimes in the femur you will get here one hyperechoic line. So don't measure that. That is the lateral margin of the epiphysis. Just like this, you have to measure the diaphysis only. And then in the brain, they have shown this lateral ventricular view. The cavum septum should be seen, frontal horn should be seen, the occipital horn should be seen, hippocampal gyrus here, parieto-occipital sulcus here. At this level, you have to measure the lateral ventricle with your calipers from inner margin to inner margin. And then the transthalamic view, the thalami should be seen, the hippocampal gyrus, the cavum septum, cerebellum should not be seen, orbit should not be seen. This is the next view, the transcerebellar view, in which you see the cerebellum, cisterna magna, and the nuchal fold thickness. Now, transcerebellar view, you can acquire at any level. From any level, you can see the cerebellum. But this has to be a suboccipito-brachmatic view. That is, from below the occipit, your angle should be towards the bregma, at the junction of the nose and forehead. So how do you make sure that you're in a suboccipito-brachmatic plane? You have to make sure that in the transaxial plane, the cavum septum is also seen. At that level, take the transcerebellar diameter. Now measurements. Some people give too many measurements in the reports. Some people give only the biometry. So as per the ISWAC guidelines, you have to give the biometry and the measurements of the lateral ventricle, transcerebellar diameter, and the cisterna magna. This is all the mandatory measurement that is required. Apart from this, if you are giving more measurements, that is your choice, but it is not mandatory. Now for the spine, this is the sagittal view, or rather I can call this a slightly parasagittal view. This, when you see this conus medullaris, this you cannot see in a sagittal view. Why? Because the spinous process will be there. It will not allow you to see the conus. But this you can very easily get when you go slightly parasagittal and obliquely tilt your probe. So this is not a sagittal according to me. This is a parasagittal view because we are able to see the conus here. And conus L2, L3 level, it will end usually. In case of lumbosacral meningocele or meningomyelocele, if the you will see that the conus is continuing, that is a case of tethered cord. So these are the transverse sections of the three echogenic points in the spine, the vertebral body, and posterior elements on either side. Just by seeing the images, we can make out, yes, this is the clavicle, so this is cervical spine. Rib is seen here, this is thoracic spine. Kidneys, so this is lumbar spine. The iliac bone, this is the sacral spine. So at each level, they have taken the axials. This is for the heart. They have given the four-chamber view. They have measured the transverse diameter of left ventricle at the level of annulus. So this we can also say it is the mitral annulus they have measured and tricuspid annulus. No need to measure in your anomaly screening. Just show the four-chamber view. If you're thinking that there is a asymmetry, then you can measure. Routinely, there will be a slight asymmetry. Right ventricle will be 1.4 times larger to the left, 1.4 to 1. That is the ratio. But if you're seeing grossly, there is some discrepancy, then take the measurements and suggest a fetal echo or learn fetal echo yourself and start doing the fetal echo in such cases. This is the LVOT and this is the RVOT. Now, this is the set of all face images. So the lips, coronal, sagittal for the orbits with the lenses, the upper and the lower limbs, the cord insertion, the bladder, the kidneys, and again the spine. This view in the spine, the sacral tilt is very important to rule out sacral agenesis, caudal regression syndrome, all those things. Now, some images.
Cord insertion image needs to be at the level of the bladder with this one. Or,
Cord insertion.
double vessel will be taken.
That is, you mean the along the bladder, the two vital line arteries going like that. Yeah, that view is there. See, in this, in the ISWAC guidelines which were they have published, they have shown the cord separately and the bladder separately. So let us check whether in the guidelines they have mentioned this is their own guidelines in the pelvis, pelvis bladder, both umbilical arteries. So this is not given in the guidelines, but they are given here. The images which I have acquired, I am routinely acquiring bladder with vital line arteries. That we'll see here. So now again, the machine which I am using is not a very high-end machine. It's a mid to mid-high range machine. But I think it is having sufficient clarity, minimum for the anomaly screening and all. So this is the lateral ventricular view. Cavam is seen, anterior horn is seen, posterior horn is seen. So just when we are seeing the lateral ventricle, the far lateral ventricle, we won't be able to see the near lateral ventricle. So what you do, just slide over your probe and rock a little bit, and you'll get the other, the near lateral ventricle also. And this is the transthalamic view with the thalamus, cavum, septum, pellucidum, leading to leading edge and the head circumference. This is the transcerebellar view, axial view with the cavum seen. Now there is one more thing I have done here. I have not taken it horizontally. The fronto-occipital angle also I have given here to make it little oblique. If you see the image given in the guideline, you will see that there are some fuzzy margins here. You cannot measure the nuchal fold thickness properly. You cannot exactly be sure, okay, what is this externa magna dimension. But if you give slight tilt to your image, fronto-occipital tilt, then the image becomes crisp like this. Now this is also, now just I have put in some of the images as practice images only. All the images which I am showing are not mandatory. Mandatory are only those which are listed in the guidelines. Okay. So this is a corpus callosum with pericallosal artery. And this is for the coronal view of the nose and lips. The mouth is opening and the mouth is fully open, baby is yawning. If you get this view, you can be very lucky. You think you are very lucky because you can be very sure in ruling out cleft lip. This is the premaxillary triangle, the two nasal bones, the nasal process of maxilla, the palatal arch here. So we have to see the continuity and integrity at this level. This is also premaxillary triangle. This is the palatal arch. This is continuous here. Now, one view which is mentioned in the Fetal Medicine Foundation guidelines, not in the ISWAC guidelines, is this view, the maxilloalveolar ridge. This is very, very important, and especially for my scans, I feel it is very ensuring this view to rule out cleft lip and cleft palate. Also, just in this view, if you scan little posteriorly, you will see the equal sign of the uvula. That is a sign to rule out cleft palate, isolated cleft palate. Even in the profile view, apart from the nasal bone and the facial profile and the mandible, you can also look for cleft palate here. There will be a palatal gap here in the mid-sagittal plane. You can see the tongue protruding up also if there is a cleft palate. So this is the transorbital view. This is always you need not take the measurements. Just imagine a third eye in between the two eyes. If that is looking equal, then everything is fine. Look for the
positive like left lip palate.
Yeah, that is coming up.
Because I have not seen it.
Yeah, we have one. So these are the orbits, these are the lenses. Look for cataract, and sometimes you see the vitelline artery coming here. That is normal. Just take some, always see these planes images. They were originally described when the machines were not so advanced. Now always we have the option of making cine clips. So try to take maximum clips as much as possible. So here you can see the eyelids, even the eyelash of the baby. See the eyelashes. From the eyelashes to the eyelids to the orbit to the lens. You can see it entirely. Of course, the nose, lips, and all you are checking here. And the profile view you can try to take. Sometimes you'll see the baby putting the thumb in the mouth and swallowing. This is a very good indication. If baby is able to swallow like this, then you can be assured that there is no esophageal atresia and all. And if possible, in this view, just put on your color also. If there is any esophageal atresia, like then you will see the baby vomiting. In the color Doppler, you can make it out. 3D, 4D, always better for surface anatomy. And also if you're taking the MIP, MPR, they are very good for ruling out your cleft palates. And for spine also, it can be very helpful. These are not 3D or 4D images. These are 2D only I have taken like this. This is the coronal plane and this is the axial plane. This is the sagittal plane of the spine, the two lines, and the third line is the intact skin. Always make sure there is some amniotic fluid around the spine. If it is adherent to the uterus, then you cannot be very sure of a defect. And this again to look for the sacral tip. Now this is the neck of the baby. Look at this view. There is no tracheomegaly. There is no fetal goiter. There are no cysts and masses, jugular sacs and all in the axial view. This is sagittal axial coronal view. Look at the larynx. If you start the cine here, you can see the laryngeal contraction, fetal swallowing and all. In this view, if there is esophageal atresia, you will see the dilated esophagus here. So thorax, look at the heart and lungs. The lungs right and left in sagittal view. Look at the diaphragm intact on both sides. And now coming to the four chamber view of heart. The scanning for fetal heart doesn't start in the chest, it starts in the abdomen. First, assess the laterality of the baby, and then if you're sure stomach is on the left side, then go into the thorax, check the situs of the heart, the size of the heart, and look for the symmetry. And you can see here the pulmonary veins entering. Minimum two pulmonary veins should be seen, one on either side entering the left atrium. When you trace and come up, actually you'll see the right IVC entering the right ventricle also. Foramen ovale, this is the crux of the interatrial and interventricular septum. There is a differential insertion. The tricuspid wall is slightly distal to the mitral valve. This is the left ventricular outflow tract, left ventricle aorta coming out, and this small dot what you are seeing here is the valve, aortic valve. So it will just come and glow. Oh, go. That is the aortic valve. It just blinks like that. That is how the valve looks on the scan. This is the right ventricular outflow tract, right ventricle, pulmonary artery. This is the right branch of pulmonary artery. This is the ductal arch going into descending aorta. Now, apart from that, the extended basic scan also nowadays they have recommended to do. That is the three vessel view, pulmonary artery, aorta, and superior vena cava should be seen in line like this. And next is the three vessel trachea view. This is known as the V sign, where the pulmonary artery and the aorta come and go in the descending aorta. Three vessels, superior vena cava, aorta, pulmonary artery. These are the three vessels. This is, you're seeing a black dot here, that is the trachea. This is known as three vessel trachea view. Then the arches, this is the ductal arch. It will be flat. It will come from anterior part of the thorax, that is the anterior ventricle, that is the right ventricle in sagittal view. Then the aortic arch with the head and neck vessels arising from the center of the heart in sagittal view. The left ventricle will be in the center. The bicaval view, SVC, IVC entering the right atrium. So now that was about the scan views which are required for anomaly scan. Now there are two innovative techniques which were described by me for fetal echo. So when I say, okay, I have discovered something new, it has no value until it is approved by an international scientific committee. So ISWAC scientific committee, I submitted it, they accepted it also. They allowed me to present it in the ISWAC World Congress and it got published in the indexed journals as well. You can see here all these journals it is published. Even the name of Aster has come in the journals. What is full trace spot? Full trace spot is a single spot on the fetal thorax. When you reach that point, uh, first let me tell you why we are doing this full trace spot. You know, there are very good guidelines to look at the four-chamber view of heart, but very less description on how we should scan the great vessels. And for scanning the great vessels, the first thing they keep in mind, you can go through the literature, they say, okay, the great vessels are very twisted and turned and angulated. So we cannot scan in that way to catch their course. We have to consider them as a vertical and just keep taking transverse sections through the great vessels, like how we saw three vessel view, three vessel tracheal view, like that. Now full trace spot, what I did, instead of going in the standard axial or the perfect axial plane, which is little bit imperfect for great vessels, I came with a plan of making the plane oblique. And in an oblique view, little bit twisting the probe in such a way that from a single point, you can trace the great vessels, aorta and pulmonary artery completely from their origin in the ventricles till their termination in the descending aorta. You can see this video. This is the four-chamber view. Now we are seeing, if you are doing routinely the fetal cardiac scans, then you can catch up with this clip itself. You can see there the LVOT, the ascending aorta, and then that is the transverse arch of aorta, the crossing of RVOT, LVOT, the ductal arch also is seen. So you're able to trace each great vessel right from the ventricle, all their course, all along their course, you're able to trace it going into the descending aorta. And also you're able to make the spatial relationship, that is the crossover. Now, after describing this full trace spot, I described another thing known as the extended full trace spot. In this, what we did, we included the four-chamber view also. And after going to the great vessels in the transverse oblique view, we made it a 90 degrees tilt also in such a way that the distal transverse aortic arch is also seen, which is a common place of coarctation, which is one of the most commonly missed anomalies. So we described a technique where we can clearly see even the terminal part of the transverse aortic arch and making the probe 90 degrees there to get into the ductal arches also. That is the arch view which we saw in sagittal plane. So everything from a single point in the fetus. Where is this point located? In the transverse view from four chamber, you are going to the LVOT, LVOT to RVOT. Now, in between RVOT and LVOT, there is a point which is very non-specific. At this point, if you make the probe oblique, you will get this view. So how I reached that point? Why will I choose that point where neither RVOT is there nor LVOT is there, nothing is there? How did I come to know if I turn the probe obliquely there, then I will see all the views. So I think I'll show you the clip. So this is the extended full trace spot. You can see in this view from the abdomen we started, four chamber view we are seeing, great vessels we are seeing. Now between the RVOT and LVOT, there I make the probe oblique. We see the LVOT clearly. We see the ascending aorta, the transverse aortic arch, and then we turn for LVOT, we turn the probe slightly towards the right shoulder of the baby. not too much, only 15 to 20 degrees. That is the orientation of the aorta. But now for RVOT, you can see the RVOT, the branching of the pulmonary artery. For this, for RVOT, we rotate the probe towards the left shoulder of the baby. And this is a significant rotation of around 70 to 80 degrees. And now we are making the full 90 degrees turn of the probe. We are going from the transverse aortic arch. You can see it opening nicely. Both the arches are seen in that plane. So the arch view also we get it in this. So this is the extended full transport. So how I reached that spot from where we can start our oblique planes and go into the right angle plane, the mid sagittal plane. I just went in a reverse order. I first saw the sagittal views and then I tried to turn the probe reverse and tried following the path of the arteries and then just reached that point from where all the story begins. So not only in second trimester, full transport, this technique can be applied in first trimester as well. This is a 11 to 12 weeks baby, not 11, maybe around 12. So you are seeing the four chamber view, and then as we move up and make the probe oblique, we see the aorta, the pulmonary artery. The artery is going into the descending aorta, the crossover of the arteries. Another clip showing the FTS, three vessel view. Then this is the three vessel trachea view. Again, the three vessel, the transverse aortic arch. Then, so what we are doing, we are making the probe oblique. Why the probe is oblique? Because you can see the ribs. When the probe is transverse, you'll see only one rib on either side, but here multiple ribs are seen. You can see the crossover of the great arteries, the three vessel trachea view, the entry of aorta and pulmonary artery into descending aorta. Oh, I think we'll go for the next clip. This is the same thing with color, the four chamber view, and this is a very long video, so we'll skip to the next slide. That is where the great vessels also are seeing. Just we can see very clearly the 3VT, the three vessel trachea view with color. And then we can trace back the great vessels into the baby's heart. Now another technical innovation which I described was the Y dot dot sign. What is Y dot dot sign? This is the three vessel view which we came across. Now in this three vessel view, how can we be sure that this is pulmonary artery, this is aorta? Maybe this is aorta and this is pulmonary artery. What happens then? Then it becomes transposition of great arteries, TGA. So now for this, I described a technique where instead of getting this type of dash dot dot sign, you can get a Y dot dot sign. That is at the level of RVOT, make the probe obliquely tilted towards the fetal head, and you will get this view. You will see that the first artery is branching laterally here like this. So it looks like a Y, not like a dash. And now you can be sure that only artery which gives lateral branches is pulmonary artery. So there is no transposition. You can be sure about that. So this is the Y dot dot sign. Now back to basics. We were in the fetal thorax, fetal heart we have completed, coming to the abdomen, stomach, umbilical vein at the level of portal sinus, one rib on either side, and AC we have taken. Umbilical cord insertion. So cord insertion, next thing is the placental site of cord insertion. Then one more thing, when you are putting on the color, just look at the ductus venosus also, because some portosystemic shunts may be there, ductus venosus may be absent, DVA genesis. Look at the kidney in sagittal view, in the axial view, and this view is also very important in the coronal. Just put on your color and look at the renal arteries, sometimes suprarenal also you'll see there. And this is the view which Dr. Sumit was asking, but he left. Oh, okay. So this is the bladder and these are the vital and arteries on either side. And after checking all that, come down. And again, I'm telling you, these are not mandatory views. These are just, I'm sharing some views with you so that we can practice it for a good practice point. These are rather good practice points, not like a mandatory view for this scan.
Guidelines, there is gallbladder also.
Yeah, see, gallbladder is not there in the guidelines, but we routinely see gallbladder. When we, yeah.
But
So-
ears are not there in the guidelines.
Ears are not there in the guidelines, but always we are checking for ears also. But I am saying, so there are so many things which we are not seeing, and these are not part of the guidelines. That is why we call these as the basic guidelines. That is, this is the basic minimum requirement. Less than that is not acceptable.
What is DHA?
DHA requirement is similar to ISO guidelines. They have also given a guideline which is very similar to ISO guidelines only.
Seeing the gallbladder, can you recall the patient again? They only mentioned because like.
Gallbladder agenesis. Gallbladder agenesis is one condition. So you can of course call back the patient and look for it.
Once there was a case like that, that's why I'm asking. Yes.
Hmm?
He's asking what is it?
This image. Yeah, this is the anal sphincter complex. Anal sphincter complex. This central thing is the anal mucosa, and this is the hypothalamic thing is the muscle of the sphincter. So if this echogenic dot you are not able to see there, then think about anal atresia. Bowel dilatation always may not be there. So if you are seeing there, you can be sure that there is no high anal atresia, which is the dangerous one. Low anal about it, it may be just a membrane, just a digital examination will release it. So the serious one, the dangerous one is the high anal atresia, which can be ruled out by seeing this view. Now, this, as I told you, in India, there is problem in seeing the gender also, but in this country, we have to see, we have to check. For the gender, they say the axial view, but just let me share this oblique view with you, because this in this view, you can be very sure that there is no hypospadias. In hypospadias, you will not get the tip of the penis like this. It will be blunt, it will be buried in the scrotum. And if you're lucky, you can see, put on the Doppler, the baby making pee. No, that is what you have to take time. So, and the time should also be good time to catch this. Actually, in this country, documenting, no, in this country, there is no issue. I was just reviewing about it. If you have come to know anything else, then let me
So
know.
because, legally, I don't think there is an issue, but sometimes parents, they want to know, they don't want to know.
Yeah, in this country, yeah, in this country, even documenting is not a problem. NIPT, which is a document itself. No, not mandatory. It is up to your person. Or you can just tell the patient or give it in a separate slip. So
Put them so when they want the gender, that is different. But
that is the thing. But in this country, you can be relaxed about it. That is one thing. It is not as strict as in India, where you should not see the gender, where you should not reveal the gender, not like that. Of course, you have to check whether there is any hydrocele or hypospadias or undescended testis. Okay, now in the first trimester, we can make out the age by the genital ridge angle, but that is not accurate. Better one is at the anomaly scan. Yeah.
Some gynecologists who predict, and then the patient comes to us and said, gynecologist said this is male.
Always it will be
I said, "No,
female.
you come back."
Okay, so now here we should be aware of the umbilical cord also. So we have to take a cine clip always. This was actually when the baby was making pee, cord was far. But sometimes you will see the cord also overlapping the genitalia. take a clip like this. See, this is the umbilical cord there. Look at the testicles like this. They should be descended. There should be no hydrocele, no hypospadias, which is better seen in the oblique view, which I showed before. Now, this is the coming to the limbs, the femur length. The femur should be horizontal, not oblique. It will cause foreshortening. And about the specular reflection from the epiphysis, already I told you not to take that, only the diaphysis measurement. And the tibia and fibula, the feet, the relationship of foot to the leg, right angles, no club foot. Just take a cine clip, very easy, simple way. Both the legs, and you always have to trace the lower limb. So one lower limb you will see go to the pelvis of the baby, and from there come to the other lower limb. It is not like I will check one lower limb, then forget the other one, later I will check the other lower limb. No, you will confuse with the same limb again. So check the femur, go to the leg, tibia, fibula, check the relationship with foot, check the foot. If you want to see the toes, see the toes. Then in that order, come back again, foot, leg, thigh, and the pelvis. Then there you go to the other lower limb. Same thing for the upper limb also. You have to trace through the shoulders of the way. This is the foot toes of the foot.
Digits are supposed to.
And it is not mandatory, but it is a good practice to see. No, DHA guidelines are very similar to ISO guidelines. It is not mandatory. If you see miss polydactyly syndactyly, it is. Yeah.
They will create a problem. Gynecologists have told that patients have started shouting and
Yeah, actually, we saw some medical legal cases also for this. That's why in these guidelines, first thing they mention is these guidelines are for having a good quality practice, not for medical legal purpose.
The comment we have down that the
It's
correct
not valid. You're right, it's not valid. That is your what DHA uploads. I mean, their guidelines is
according to DHA.
No, even in DHA, digit counting is finger counting is not needed. Yeah.
supposed to take.
That is what I'm telling here. See here, all long bones I have measured here like this, but this is what I was doing before. All measurements are not mandatory. What I told you, the biometry measurements, the transcerebellar and the ventricular diameter, that much is enough. Other things, cisterna magna also, other things are not mandatory. If you are in doubt, okay, the limbs are looking short, then you can of course measure it like that. Otherwise, it is subjective only. Subjectively, you can easily make out. When you're taking the FL there itself, you'll get the idea about the limb length. And of course, by eyeballing. Now, coming to the fingers, you are asking. This is a good practice. Always look for the open hand. All 5 fingers are present. All the phalanges are present. Tips of fingers are present. All are separate. I think already we saw this slide. Spine. Cervix. For taking the cervix measurement, it can be done transabdomen or transvaginal. The cervix should be seen, the central mucosa of the cervix, the cervical plug, that should be seen. And the anterior lip and the posterior lip, they should be equal in width. And the bladder should be seen, the small pocket of amniotic fluid should be seen, the image should occupy most of the screen. In that way, measure the cervical mucosal plug, not the entire cervix, because we cannot be always sure where is the internal os, where is the external os. So cervical length actually means this thing. So make sure that you're not getting a image with too much shadowing. And if you are doing a transvaginal scan, there is a technique to improve your clarity of image. When you're seeing it, the cervix, just pull your probe back and then reinsert it to get a very crisp image. And this I have used a trace method here, but it is not always mandatory to use a trace method. That's because when cervix is short, it will be straight. So even without a trace method, you can make out a short cervix just by straight measurement. And this is placenta to cervix relationship, very important to see. This is not a part of ISWAC guideline, but Fetal Medicine Foundation, it has this guideline to check the distance between inferior edge of placenta and the internal os, which is less in this second case, so low-lying placenta here. So what we'll do for Aster, we will have customized guidelines, taking into consideration some important, like I showed from Fetal Medicine Foundation, two things till now which are not there in ISO guidelines. One is the inferior edge of placenta to the cervix. Another is the maxilloalveolar ridge. So such important planes which are missing in one guideline, we can add it and have a customized guideline for ourselves.
Customized file.
Yeah,
That is the problem. So much. Yeah.
for that, I'm telling you the technique is go for cine clips. Don't. That is what I told you. No, there will be an option. There will be an option in the machine. 30 seconds, 60 seconds, 120 seconds. Then it goes on till maximum. So.
No, actually, even if you store it in the machine, you go back to like packs.
Exactly. This problem they told me in Medinova also. Transfer to PAX is not taking. So Rebecca is here with us. Work with Vakar. The cine clips are not transferring to PAX. So this has to be resolved.
And they don't transfer to CD also.
Yeah.
The image documentation which we are giving to the patient.
CDs, none of them can.
Videos don't.
Yeah, this is a local. Yeah, this is a operational issue. So good, Rebecca is with us. She will resolve it. Because in Abu Dhabi, this problem is not happening. Even 3 minutes videos I am recording, they're fully transferring. No, too much time now when we started in Abu Dhabi since then. Maybe 2 years or more. Okay, welcome.
Can we arrange for
Then- Application specialist, yeah. But that is,
My machine in Varka, what they did is, Rebecca, the machine where they put, right, they have taken all the wipes from all the walls. That is creating such a big issue to the machine that, so much of artifacts. I can't see anything in a factory, but most of the things I can't see. And they put that machine, they what, actually the application specialist came, by name Sami. He told, went off. The other, one more girl came. She took the machine and put it in one clinician's room. When he took that, it's completely different machine. She made a settings for me.
I think Dr. Kusuma, she will come to you later. Otherwise, we'll not finish the presentation. Okay, so this is for the uterine artery Doppler. There are two techniques, iliac vessel crossing level, like how I have shown here. Another one is at the level of internal os. Both pros and cons I have explained you already. Technique of internal os, the new technique already I described earlier. Now, case discussion. Where is the other doctor? She was asking for positive cases. She is doctor? Dr. Sakshi, yourself? Where you are working, Jitin? Alcos, and yourself? Rohan. JLT. Okay, okay. Nice to meet you both.
Doctor, before we come, one question. BSD,
Hmm.
what can we miss? Like, see, I know muscular VSD and all, okay, it goes, even if you miss it, it will not be a problem. If you miss a perimembranous antibiotic or something, will it be a bad thing?
See, VSD, to be frank, it is a spotter. More and more cases you see, more easily you will pick up. Sometimes without color, you will not be able to pick it up. So always use color in your cardiac scanning. And for VSD, one artifact will come in the perimembranous region, that is the acoustic dropout. So that can also be very easily differentiated. When it is a VSD, you'll see echogenic margins along the defect. That will not see if it is just a acoustic dropout. Yeah, see,
But that is only.
yeah, like a matchstick it will come. No, no, yeah, that is in the apical four-chamber view. So transverse four-chamber view, you will not get that. And the best view, when we talk about VSD, we don't consider apical four-chamber view at all. Yeah, whenever you're thinking about VSD, think about the transverse four-chamber view only, the lateral four-chamber view. Your understanding, your beam is like this, the interventricular septum should be perpendicular to your beam. If it is coming along the beam, you will get a lot of artifacts. On that plane, you cannot be sure about. It is not necessary. Not necessary that VSD should be associated with any. It can be isolated VSD. ASD, of course, septum primum defects. We can see septum secundum. They cannot be seen on ultrasound. So it is a acknowledged fact. Septum secundum defects cannot be seen. So now case discussion, Dr. Sakshi, for you only we are waiting. You were asking for positive. So we have 4 cases, 2 closed cases. Closed means they are already worked out and workup is done. We know the result, what was the case. And 2 open cases. Open cases means recently in last week or last month, like that only I have seen. Still we are working on those cases. So you are also in Aster, I am also in Aster. I will share with you the result, what it comes, okay? So these 2 open cases, you people can tell what are the findings. And I will also tell what I was able to see. And then when the report comes, that is the either the amnio or if they go for termination of pregnancy, we can see what are the findings in the abortus. And then we'll check what it comes out. So this is the first case. You want to make a guess what you are seeing? See the clip completely. So any guess? So we are seeing only one artery arising from the heart. Yeah, common arterial trunk or truncus arteriosus. You are seeing 2 lateral branches arising from that single artery coming from the heart. See the lateral branch, see the other lateral branch, and that is going up and giving the head and neck branches also. Now, not only that, the baby had one more finding. It had club foot as well, amniocentesis array, and the result was DiGeorge syndrome.
Do you assess the fetal times?
Fetal?
Timus.
Yeah, DiGeorge, we have to, any cardiac anomaly, always first look for the thymus. That is the, see, normally for the heart, between the sternum and heart, there will be a good space. Here you see it is almost stuck to the sternum. That means there is thymic hypoplasia. That is also a marker for DiGeorge syndrome. This is second case. So tell what are the findings? Hypoplastic. So it is monoventricle. One ventricle is hypoplastic. VSD is there in this case. Difficult to assess because the other ventricle is hypoplastic. If you see that clip closely, you will find the VSD. And that is, I think, membranous VSD because it is more towards the crux. And anything else? So what about the monoventricle? Which ventricle is hypoplastic? No, it is the left ventricle which is hypoplastic. Very good. Excellent. That is the point here. The ventricle which is present on the right side is not having moderator band. So it is a morphological left ventricle. This is known as ventricular inversion or atrioventricular discordance. See further what you will see there. From the right-sided left ventricle, which is the artery coming out, aorta or pulmonary artery? Pulmonary artery is coming out. Yeah, pulmonary artery is coming out from the right-sided ventricle, pulmonary artery. But the right-sided ventricle is left ventricle. Aorta should come out. But instead of that, pulmonary artery is coming out. So this is a ventriculo-arterial discordance also, double discordance, which is known as congenitally corrected transposition, also known as L transposition. What is the meaning of L transposition? The aortic arch you will see on the left side. That is how the heart has rotated. Now, most of the people, including many pediatric cardiologists, think that there are only two types of transposition. That is the L transposition, D transposition, and L transposition is the congenital corrected transposition. There is one more condition, very rare condition, which even the pediatric cardiologists mostly won't be knowing, and that is congenitally corrected transposition with D malposition. You can see the aortic arch. It is on the right side, not on the left side. This is the other vessel, the aorta. It is on the right side. So this is congenitally corrected transposition with D malposition. Anything else you are seeing? So hypoplastic ventricle and VSD, ventricular inversion, ventricular arterial discordance. Any gross discrepancy you are seeing between the aorta and pulmonary size? Now, one is saying aorta is small, one is saying pulmonary artery is big. Dimensions, if we take, both were abnormal. There was aortic hypoplasia and pulmonary hypertension. If you see the origin of the lateral branches, check at the pulmonary artery. The main arterial trunk is very much dilated, but the side branches are very narrow. This was bilateral branch pulmonary artery stenosis. So this is another finding. Aortic hypoplasia is another finding. Now I don't have the color image, but when I switched on the color, there was a forward flow. But at the termination into descending aorta, there was a reversal. This is a sign of early coarctation. You will see a nice forward flow. You will think aorta is normal, but there will be a terminal coarctation, and later it will develop into more significant narrowing and hypoplasia of the aorta. And that is the sequence of HLHS kind of sequence, hypoplastic left heart syndrome type. So now one more differential which I had given, one was complex cardiac malformation. Such type of malformations, you cannot put it just like transposition or just VSD, or one category you cannot fit. There are so many things in it. So such kind of malformation, we call it as a complex cardiac malformation. That is the name given to it, complex cardiac malformation. Another differential was double outlet right ventricle. It is a very close differential to such cases, but ultimately this baby was operated, and all intraoperative findings were all those what I have already described. This is the baby, 1 day old, operated, and the baby later, the baby is doing well. Now, those were the cases which were already worked up, okay? We had the result. Now, next two cases, we don't have the result. I am showing you the cases so you can tell the findings. It was referred from elsewhere as amniotic bands for second opinion. So in the first image, you are able to see amniotic band here. In the second image, you are seeing many amniotic bands here. BPD is coming very small, around how much? 16 weeks, but GA wise, she was around 19 weeks. The femur length also is showing very small. So when you get such type of biometric variation at this age, at 20 weeks around, think that there is some anomaly. Usually anomalies will cause IUGR, especially think about chromosomal anomalies. They will be associated with this FGR, growth restriction kind of thing. So when we saw in more detail, we saw, okay, those bands are around the abdomen, around the chest. This is the chest, this is the abdomen. Everywhere we are seeing these bands, but all along the baby's surface. Exactly. This is a case of cystic hygroma. So these are not amniotic bands. This is within the baby's subcutaneous tissues, fluid collection, edema, and these septations. You can see extensive pleural effusion. What else we are seeing? There is hyperechoic kidney, dilated, that is hydronephrosis, grossly dilated. This one.
This was
Again,
19 weeks.
at 19 weeks, but corresponding to 16 weeks by ultrasound. So here we can be more sure that this is actually a cystic hygroma. That is what we are working on. This is open case. So you can tell from here also any more findings. Heart totally compressed because of extensive effusion. Fetal ascites is also there. Yeah, that is the thing. We can think about hydros because more than two cavities are having fluid. But I measured the TI index, MPI, myocardial performance index, it was normal. So this is incidental heartbeat is looking very fast, but when I measured, it was normal heart rate. Now what I am doing here, anyone can explain? So many cases come reported out.
Echogenic bubble. You're comparing to the
Exactly.
bone.
Yeah. So many cases come for second opinion for echogenic bowel. So this is how I decide, and almost till now, whatever cases I have come, I have given as no echogenic bowel. But this is one case where actually there is echogenic bowel. So what you do, lower your gain completely, then slowly start increasing the gain until when only the bones are seen. At that point, if you are also seeing the bowel with the bone, that means it is echogenic bowel. So now even more sure we can be in this clip that it is cystic hygroma, not amniotic bands. Even the head shape is not very uniform. It is a little bit disorganized. Even the internal cerebral structure is disorganized. I measured the ventricular size also in this, a little bit dilated only. Even this in this clip itself you can make out. So like this, when by eyeballing you are seeing something abnormal, you can definitely measure that. Now in this clip, just trying to check the limbs of the baby, the fingers, whether they are polydactyly, syndactyly, that was not there, or that is there. No, not sure. That's why I took this cine clip to check in transverse axis. And here I had more doubt. Okay, these two fingers are fused together. So now what I am doing here? What is the difference between this and this? Same thing I am seeing, but different images. What is the difference? This is a gynec setting, that is obstetric setting for anomaly scan. I have changed it here to musculoskeletal setting. So always with your left hand, you have to keep playing with the machine, keep adjusting the settings always. And in this, we can be more sure that there is actually a syndactyly of the middle two fingers, middle finger and the ring finger. And all long bones are short. Again, when you have doubt, measure everything. And this is what? From the cord insertion, only single umbilical artery is going there. This is the MPI, also known as T index, 0.4 normal. And whenever there is anomaly, try out everything: curvilinear probe, linear probe, transvaginal probe, 3D, 4D if you have, use that also. So everything, and every part of the baby. So this is TVS. This is how we saw the baby. This is the head of the baby, the spine and the body. And see how much this edema and fluid collection along the baby, all this. So that is one case. Any more finding anyone is seeing? This patient we advised for invasive testing, but the patient went to India for termination. I'll try to get some follow-up with that patient.
So the patients you pick up something will go to, yes, we don't get a follow.
Oh, but you take the number of the patient.
I tried to trace so many patients. They
Mm.
stop talking to the gynecologist. So I think we've done something to the baby.
Oh my God. I hope this patient will give feedback.
And most of the people get another ultrasound done in India, like from fetal medicine, and then like try to do their absent boy,
Yeah.
like a little findings they will there. And then they will call the gynecologist will call you.
One patient had given this placenta. No, that was a case of scar discence early in pregnancy. The patient again, as she said, they went to India, got it done by fetal medicine there also, and luckily they got the same report because here the obstetrician told them, "Okay, this is very early to detect the scar discence and all. It's not possible." They went there, they got the same report. They came back again to me. Maybe it was second trimester, early second trimester only, 18 weeks maybe. This is the second open case. You want to make any guess what findings are there? Yes, by this image, first thing you will think is a neural tube defect. Surrounding, there are amniotic bands. There is more amniotic band, more over here also. So just anything else you want to think? It can be either a neural tube defect giving rise to all these complications, including the amniotic bands, or it can be the bands itself causing the dysraphism in the baby. And the baby was continuously stuck to this part of the placenta during the scan. After 1 hour, I repeated the scan, still baby in same position, called the patient on the next day, still baby in same position. Repeated scan again after 2 hours, still baby in same position. So this is the skin defect is also seen. Spine is also not continuous here, but the cord is looking intact. So this is how in case of spina bifida, we have to check the case. First the defect, this is showing the defect here, the size of the sac, and localize the sac. Look at the cord here always, underlying cord should be normal. How do you localize the level of spina bifida? Kidney at what level you will take? If there is a unascended kidney, if there is unascended kidney, then so
Ribs.
ribs is another way. Usually 12th rib will be D12. But if there are 11 pairs of ribs, anyhow we are suspecting the neural tube defect usually associated. So one thing what they have told is usually the last vertebra at 18 to 20 weeks, which is ossified, is S4 vertebra. So this is most definitive way till now they have described. The S4 vertebra is the last. Trace the last vertebra, from there keep on counting reversely till you reach the level. So again, you have to prognosticate the case also. Always these dorsal spinal dysraphisms are having a more poorer outcome. And then you look for other associated anomalies. What are you able to see here? No, count the 5 are only there. Yeah, there is cleft lip and cleft palate. See, we are not able to see that our typical plane is there, no nose and upper lip. That is not seen there. We are seeing clefts in that. And I think that is bilateral cleft lip and palate. And in the fingers, the index finger is continuously bent. So although clinodactyly is common in little finger, but the index finger sometimes just I have doubt. So this is for the cleft lip and palate. You can see not able to get the nose and upper lip at all, continuous defect. And this is the finger I was telling, continuously in this position, maybe clinodactyly. And the umbilical cord insertion to placenta, it is not inserting directly. This is the point of entry. It is inserting at the periphery of the placenta along the surface. It is creeping and coming. Two possibilities are there. One, it can be a filamentous cord. Another thing, because the adhesions are also in this place, it can just be a tethered cord to the placenta due to the amniotic bands. Okay, this is for the feet. This is going from the leg 90 degrees. See here, this is the leg. All long bones are short, of course, leg length is also short. And this is club foot. It should go 90 degrees, it is just turning like this. This, if you see in a cine clip, you'll feel like the baby is saying you bye-bye with the foot. Instead of hand, the baby will be waving the foot at you. So, this is for the spinal dysraphism, the bony spina bifida, to check the defect in the bones, just comparison with one level down. This is the intact spine like this, whereas here you can see the cleft. This is the skin cleft. And coming to the head of the baby, the shape was abnormal. Entire cerebral parenchyma was disorganized. The ventricles were dilated. There was a cyst, interhemispheric cyst. Measured the cyst like this. And this video is to just trying to search for the cerebellum, cisterna magna not seen at all. Cerebellum is very hypoechoic, almost abutting the occipital bone. So these are all the typical features associated with the spina bifida.
We see normal posterior fossa, can we for sure know that there is no.
Not necessarily. The cranial findings are secondary findings of spina bifida. The only diagnostic finding is either you see the defect and rule out, or you see the spine and make sure okay, there is no defect. That is the only way to rule out. Carefully, you have to say.
Sometimes you're in a hurry.
Know what I should say for that. Okay, thank you. 2 hours it took, no? Or 2.5? 4:15, 2.5 hours. Huh? And thank you, and sorry for very long presentation. Next time we'll have short topics, and we'll ensure that this is not just theory discussion or something like that, but proper practice which we are putting into effect.
So if we get some positive doubtful cases, can we send them to you? That's what I was thinking. But then you're in
No, but now we have a common tax. So the issue Rebecca will resolve.
Yeah.
So that
Peer review or not peer review.
the meeting we can close.
Thanks to.
So everyone is still attending or
I
everyone
think
left?
Dr. Namita, Dr. Isha, and I think Kanwar doctors.
share in between.
This
First we will discuss, then we'll go to.
So that was a transcription, that's fine. Thanks, Dr. Namita.
I think everyone left already.
Oh, no, we are here, Dr. Fayaz. We have not left for anything. We are still here.
Okay. I thought
Looking
no
at
one
your
could
eyes.
survive.
No, we are still here. Very, very exhaustive presentation. I can see that you've made a lot of effort in making this. And also that you're very passionate about fetal medicine.
Yeah,
So,
but
and
thank you so much.
congratulations on the 2 techniques of yours which are published in journals as well. So absolutely.
Okay, thank you so much, Dr. Namita. Thanks, then.
Okay, logging off. Thank you.
Okay, bye everyone. Bye-bye. Good evening. Good night.